So thank you, Stefano, for the introduction. This talk has two components. I'm going to describe planned research in hospital emergency departments, where the first study is about to commence in Australia. The funding for this project has come from the PolyU Faculty of Humanities Dean's Reserve, for which I am tremendously appreciative. The research in Australia sets the scene for a larger collaboration with other countries. This collaboration will be with this centre, my centre, and my Memorandum of Understanding partners. In this talk, I want to discuss the research overview and tell you a little bit about that first study. I decided to give this talk to demonstrate what the centre plans to do over the coming years after I have stopped being director, and why we have started this project, challenges and all. I also wanted to ensure that my clinician colleagues and academic colleagues in Hong Kong are apprised of the research and will recognise its value. Although I have commenced this research in Australia, my goal is to have collaboration with Hong Kong hospitals. The second component will be Dr. Amos describing the background research that has been going on in the past year. The background map here is of an actual emergency department, but the foregrounded part right now is critical. Some of you will have had experience of emergency departments and even work in them, and you'll know how they operate. I welcome your input this morning, or indeed via email later. The aim of the International Research Centre for the Advancement of Health Communication is to collaborate with researchers, clinicians, and with the community. So input from clinicians and health scholars is important. But I know that some of you may have been ED patients or observed ED care of loved ones, and your experiences are valuable to this research. The emergency department is complex, and for many of us, an unknown entity. This slide demonstrates sources of information that are out there, from the designing of the ED space, which is an important aspect, to the professional ED bodies around the world, and other literature review sources, or of course, information on the media and things you can get when you go to look at YouTube. As a quick overview, emergency departments vary enormously in size and staffing. So the scope of an ED and the treatment they provide depends on their size, geographical situation, and their resources. This is why people are sometimes flown from one rural hospital to a tertiary hospital in the city, because the treatment is not available where they are. Just very briefly, there's usually a triage system when you go to emergency. So if you've just got a splinter in your hand, you'll probably be a 5. If it's a major resuscitation issue and you've had a serious trauma, it'll be a 1. And you're assessed according to what's wrong. In Australia, we have adult and pediatric emergency medicine, but that's not the case everywhere. And in general, admission rate is lower than nighttime admission rate is lower than daytime. But there's a big but here. As you can imagine, there are times when the evening gets really busy, and Fridays are a peak night, as are Saturdays, as are when there are big events on, as the Rugby 7. I'm sure our emergency hospitals were very busy, and public holidays and the like. So what that tells you is it's a very unpredictable situation that health professionals who work in ED find themselves in. Also, not to frighten you, but the scope of care that surrounds the emergency department is enormous. The ED is a unique setting, as the clinicians and nurses have to deal with the unexpected, the unusual, as well as the worried well, who attend regularly at ED, but for other psychological or social needs. The focus on ED handover is because handover, or handoff as it's called in the US, is a critical aspect of patient care, and handoff is often noted and recognized as a weak link in patient care. Handover, I'm going to use that term because I'm English stroke Australian. Handover simplistically can be described as handing over information about a patient from one professional to another. It can take many forms and does not have to happen in isolation. But it does not happen in isolation, but rather it co-occurs with other aspects of patient care and treatment. Handover is a recorded point in the patient's journey and is all about assessing the patient's conditions and needs at a particular point. Handover can occur across a number of situations: shift-to-shift handover, nursing handovers, night doctors, day medical staff handover, post-operative handovers, hospital department ward transfers, and also hospital to hospital transfers. The list goes on. Our studies focus on handover in the emergency department of a hospital and represents research that my colleagues and I have planned over the past year. Please excuse me. I'm doing better than I thought I'd do, actually. So we have commenced the research by talking to clinicians about shift handover as a specific event in ED. There are other handovers when patients are transferred from ED to a ward or operating theatre. But we decided we must start small if we are going to work on this area for some time. Our hope is that these specific topics will spawn a number of new avenues of research, but for the moment, shift handover is focal, and these questions are key. And these questions that you see on the screen were developed in conjunction with ED clinicians in Australia. And we're asking, what is the effect of time degradation on the quality of handover? Because, different times of the day, you've been working all day, how does that affect when you do a handover? Other aspects of fatigue or stress. How do clinicians manage different styles of ED handover? Because while there is normally a standardized way to hand over, clinicians have their own way of doing it, and that can make a difference. How do clinicians deal with the constant interruptions they experience? And they do. That's the very nature of ED. It's busy, it's open space, so that people can look around and see what's going on, and you can see all the patients. It's noisy. So how do they manage that? Because they're going to have interruptions, but some of them are going to be essential. And do junior staff perceive they have a voice during the shift handover process? By a voice, I mean, do they feel that they can interrupt, ask a question, ask for clarification, even say they couldn't hear? I did a study with a colleague, and it was a situation where someone couldn't hear quite what was being said, but didn't like to ask the senior clinician, and so went ahead with the treatment they thought the person had said, and the patient came back 6 weeks later for further treatment. This happens. Having a voice is important, and the status differentials in hospitals can interrupt with that, badly affected. And then, of course, stemming from that, we have related issues about staffing, retention, staff shortages, fatigue, and the impact on communication and thus on quality of patient care during handover. Now, you may notice I'm not talking about any theory here. That's because this is a very interdisciplinary project, and I'm going to have my take on it, and other people will have their take. I just want to give you the big picture. We are hoping for a 3-phase, 6-study program of research that will be conducted with collaborators at different hospitals around the world. Today, I'm going to focus on phase 1 in detail. I will overview the other phases and mention the countries with whom we will form collaborations. But it will be a questionnaire study. It will be anonymous. All ED staff will be invited to participate without exclusion, and all collaborators across different countries will all do study 1 as a baseline. So the questionnaire protocol for study 1, ED clinicians, nurses, allied health professionals, and other staff working in ED will be invited to participate, even those who don't go to the handover, because the outcomes from a handover may impact on how they manage what they've been told to do for the patient. It's going to be an online questionnaire using Qualtrics, and by completing the questionnaire, participants are consenting to be part of the study. They can stop at any time without any consequences. And this is what they will see when they start to read it. It's much longer than this, of course. ED shifts occur at regular times of the day. Please respond to the questionnaire items with respect to particular hospital and shifts. In general, we want to know if there are differences across the different handover shift times, and also if there are differences when different health professionals lead the handover process. We're not leading them, we're just asking if there are differences. And then we actually have an overall, what's the climate like where the people work? What's the work environment like? How psychologically safe is it? And this is a measure that was developed by Dijkman in 2022. And there are 7 items, but you've got an example there. If you make a mistake in the ED, it's often held against you. So that's the sort of items that we have to get a general overview. And then we come down to, again, a perception, a sort of general perception. How are handovers executed effectively? How often are handovers executed effectively, e.g. clearly, in the ED? And then if people wish and they have the time, they can expand. Does the style or manner of the handover alter according to the time of the shift handover? Again, they can expand on it. Does the style or manner of the handover alter according to who is leading the handover? How much do interruptions disrupt the ED shift handover? What are the most frequent types of interruptions? And then we have a number of questions, of which I've only got one here, that say, when you are not leading the ED handover, do you feel confident to speak out and voice an opinion? And again, it goes on to say, or ask a question, or ask for clarification. There's a number of items there. We're getting a picture generally of how people perceive the handover. Then importantly, we are going to ask about facilitators. I think it's very important when you do this kind of research that you're not only looking at the negatives, what goes wrong in the hospital. You're not going to get an entree into a hospital if you're always asking what mistakes have you done, where have you gone wrong, how many patients have died this week because of your errors. I mean, who would want to talk to you? But the fact that you're talking about strengths means you can celebrate what people are doing well. And by looking at strengths and positive events, you can learn, why is it one hospital does this well, and this is a hospital which is seemingly in the same situation doesn't? What can you learn from that? So I think asking about facilitators as well as barriers is very important. And then we actually want people to talk about a specific handover. We ask them when was their last handover and what particular shift was it? And then we have 9 items that we ask them. And there we ask them deliberately after handover experienced an unexpected problem with a patient that I believe was not raised in handover, just to get a snapshot, if you like, of what's going on for them at their last handover. So who's involved in this research? We currently have active engagement with a large tertiary hospital in Australia for study 1, and we're commencing research with Israel, USA, and the UK. Israel is already planning their participation in study 1, and our centre is hoping to secure interest from clinicians in Hong Kong. And of course, I will be doing all I can to encourage people to talk to me about being part of this research, and I'll be reaching out to the Health Authority. Active memorandum of understanding participants are apart from our own centre, Associate Professor Neil Cottrell at the University of Queensland, who's the Director of Interprofessional Education in the Faculty of Health and Behavioural Sciences, and Professor Gavin Schwartz, who is Director of Health and Business at the University of New South Wales in Australia. We've had direct consultation assistance from various clinicians in Australia, and these are Dr. Daniel Schweitzer, who's a neurologist affiliated to the University of Queensland, Dr. Lisa Lakester, who is Senior Research Fellow affiliated to the University of Queensland, Dr. Joseph Ting, physician, University of Queensland, and Dr. Delani Mendes, who's a lecturer at Griffith University. And all these people have been able to help us come up with this first hit of the project. So there are other players who've been involved in the research journey, but these are the key players in the design. We have hoped to commence with some observations in ED, but due to the sensitive nature of the context, we've had to opt for a questionnaire. We hope that by conducting a simple and unintrusive first study and providing feedback, we can gain the trust and confidence of ED teams. Unlike when you're doing experimental laboratory work or using secondary data, it's very hard to gain access to any health context. And you need patience and flexibility if you're a researcher. To give you an idea of the challenges, it has taken a year to get this close to sign off on this project. I have to say that much of this, though, is very reasonable. This is a sensitive situation. And as Amos can testify from his review and observations, observations are often conducted by hospital insiders who can more easily gain access. And there can be a concern there that people who are in the hospital are accessing and looking at their own hospital, and they come to it without perhaps fresh eyes, if you like. The privacy and well-being of the patients is also paramount. Also, the staff are overstretched and often working long hours, and asking them to complete the questionnaire is no small request. So just very briefly, overview of the further research phases. We're going to have observations, because we've gained trust in ED, interviews with ED personnel, interviews with patients from ED, because they're part of ED and they're important and they're part of the community. And from that, we're hoping that we'll get information that will inform another questionnaire around communication and care. Then we hope to develop a model of communication effectiveness and see if that can be used as an intervention. We've got mixed method approach because we've got interdisciplinary experts. No research collaborators are expected to participate in all 6 studies. We do want them to collaborate in the first, and we hope to have shared learnings from this project. We are going to encourage collaborators to decide what they see as the most challenging in ED and work with the key research teams to get to phase 3 in a 2-year timeframe. We want to better understand the elements of effective handover for safe staff wellbeing and improved patient care. And I can take questions after Amos has presented his part of the talk, which is the second component of the research that we've been doing. So I will now hand over to Dr. Amos York. I didn't cough much.
Thank you so much for Professor Watson. Indeed, at the beginning, when I note that I will have the honor to work with Professor Watson, I start checking all the internet source and also start looking at the literature. And the first thing that I noticed is actually we got a lot of mnemonics. In the first paper that is under review, actually we also invited a medical consultants from emergency department of the Queen Elizabeth Hospital to join with us and provide a lot of valuable comments on our research. And he is also one of our co-authors. At the beginning, when I look at all the data, first of all, I noticed something. The IS bar, which is very frequently appear in the literature and also in those guidelines provided by the government. And this IS bar is actually a composite of 5 mnemonics elements, which is identification, situation, background, assessment, and recommendation. And I think, wow, this acronym is very useful because somehow it helps people to remember the details of a bigger list. So they can work out all these things more systematically and avoid missing information. But when I start looking for more resources, and I figure out actually IS bar is a derivative of S bar. And then I find out that IS bar has another definition, which has a very different components. The R is a response and rationale instead of recommendation. So I start thinking about, well, it might create some confusion if I'm coming from different hospital and going to another hospital with another system. But this is not the end of the confusion. We have I-S bar. We have ISO bar, but this is, well, this is a uppercase one, and we also have a lowercase one. And we have IS bar R. Well, if it is the end of the story, then it is not the whole part of my story. S bar, actually, they have an S bar T and also S bar R. So it creates something that I really want to look into first, is to see actually how diverse and why these things happen. So I start investigating the mnemonics. Indeed, these mnemonics are very useful because they were created by different hospitals, by different ED departments, and also different departments in the hospital to summarize the most important point in clinical handovers. More or less, there are many clinical handovers beyond the literature we read, but also there are many mnemonics that has not been published, and also they may in other languages like Chinese, like Hindu, and other languages. These mnemonics were developed by the clinicians that they have a lot of knowledge and they know these elements are very important, which contribute to a safer clinical handover in the hospital. Therefore, if we can integrate these crucial elements and organize them into a framework, we could use it to promote safer clinical handovers across departments and hospitals, and especially we can promote it across its cultures and also languages. Indeed, under my review, I noticed that there's no existing taxonomy from my review part to describe all these clinical functions and processes. And if we can develop a universal framework to describe these clinical processes and functions, then probably we can contribute something to the knowledge that we can help researchers to systematically analyze unreported or newly developed clinical handover mnemonics and compare them with mnemonics reported in our study. And for hospital administrator and clinician, they can also use this taxonomy to construct and calibrate their own clinical handover tools. And also for the non-English speaking countries, they can also use these taxonomy to develop their own system or translate their word back to English. And therefore, I started a PubMed query with these query syntax, and I got 98 articles. From these 98 articles, I read them all, and I found out there are 14 articles. Either they are review or they are just reporting their use of new clinical handover mnemonics. And I collect all these articles. Not only the mnemonics they reported in their findings, but I also connected any mnemonics they mentioned it in the literature, in the background section. And here we have 42 clinical handover mnemonics. And there are 238 elements. And then I checked these 14 articles references and also do a Google search for an earlier source of article information to describe the description of all these 238 mnemonics elements. And these are the 42 mnemonics. I believe many of you may see or may know some of this. And Dr. Park, actually, he also found around 60% of these he knows, but he haven't seen some newer one that from his professional knowledge. And here, these are the mnemonics. And for the mnemonics element, actually is a composition of the acronyms. For example, SBAR has 4 elements, which are situation, background, assessment, and recommendation. And here's the list of the mnemonics and also the mnemonic elements, but I'm not going to go through this list here. I just want to show you the list.
just candidates.
To construct this taxonomy, I tagged all these 230 mnemonics elements to create this taxonomy and group them into 20 functions of a free clinical process. And the second author, Dr. Pak, he then read this taxonomy and also those description and update all the labels function that he think it may not be it may be inaccurate. And therefore, after that, we talked about the taxonomy together and discuss all 238 elements, and we agree on those processes and functions. So I'm now going to present to you this taxonomy. Actually, there are three processes under these clinical handover mnemonics. The first process is administrative process, which contains 6 elements, 6 functions. The first one is patient information. The second one is discharge plan. The third one is medical social service. The fourth is the staffing and resources, and then the legal and regulations. And the last one is responsibility, risk prevention, and disaster recovery planning. The next one is a bigger group, which is the clinical process. It contains 7 functions. The first one is the clinical urgency, medical history, medical condition, medical evaluation, medical diagnosis, outstanding care and tasks and resource results. And the last one is the care plan. And the third group is the communication part, which contains 7 functions. The first one is culture and environment, participants, mode, manner, timing, and the final one, which is validation, which means that when they communicate and the receiver will read back the information and clarify any things that he don't know whether it's complete or he has other questions in his mind. So you can see from this pie chart, actually clinical process mnemonics elements contain 60%, 67%. And for the administrative process is 21%. And for communication is only 12%. And in administrative process, the most frequently occurred one is the patient information, and then the responsibility, risk prevention, and disaster recovery planning. The next group is the clinical process. And the most frequently encountered one is medical history, medical condition, medical evaluation, outstanding care tasks or results, and also the care plan. And for the final one, the communication process, you can see 2 very tall lines, which are the manner and also the validation, which is quite easy to understand. But we also notice one thing. For communication, if we are talking about the environment of communication, whether it will create more interruptions or less, who are the participants in that handover, and also at what time, at where, and under which kind of organizational culture, and what timing. For all these important elements talking about communication, actually there's only one study or one mnemonics handled about all these kind of things. So for me, I have a lot of questions. First of all, mnemonics is to help people to remember the longer list of information. But this list, if we look at this and we found so many clinical handovers mnemonics, it just means that probably there were some people, they forget those things and maybe they ignored it or they don't remember that they need to hand over those information. And therefore there's a need to create that mnemonics. And also certain elements which are crucial to effective communication, such as the environment, participants, mode, timing, and culture, have not been drawing enough attention. So in that case, probably a field research could show us more about the clinical handover in practice. However, if we want to do an ED research properly, without disturbing the ED team and the whole environment and create some troubles. Therefore, it's better to look for a proper ED research method. And here we come to the second one, a systematic review of ED shift handovers. This one, I'm still working on it, but I'm reporting some data I found. First of all, the most important thing, ED is a very challenging environment, and every second counts. Unanticipated patient flow, and no one knows who they are, what medical condition they have. Therefore, it creates a distressing and high-pressure environment 24/7. And therefore, and also most hospitals, they have a service patch. In Hong Kong, it's 4 hours. If some patients stay there more than 4 hours, it becomes a red alert. And people will think it is not a very efficient one, or some patient may have been ignored. And now we have a question: how can we research their workplace without disturbing their work? Because we don't want to hamper the safety of a patient just because we want to develop more research. And therefore, we need to release out all relevant ED shift handover research, particularly focused on the research setting and intervention tools used in their field research. And we want to find out the most useful shift handover practice and research methods for emergency departments. What we want to do is to contribute to find something that we can develop a ED shift handover research and reporting guideline. So far, I collected 25 research articles from the PubMed. I thought I will use Google Scholar, but I noticed that actually they don't have a very clear guideline on how to index those articles. Therefore, I find at the end I excluded it. And the keywords I use is the emergency department, shift handover, shift handoff, and also shift sign off. I excluded the multi-site survey, and also the articles that are not in the ED setting, or they are not talking about shift handovers, or they are just a review of shift handovers. And I got 25 research articles from the year 2008 to year 2021. In these 25 articles, 15 of them came from the United States, 3 from Australia, 2 from Canada, and then Belgium, Switzerland, Ireland, Saudi Arabia, United Kingdom. And their census, they have an annual visit of from 41,000 to 170,000 from the 18 studies that they reported their ED census. And for their shift, most of them, they use an overlapping shift model. And this model will be different for the residents, for nurses, for fellows, and attending. Therefore, if we are comparing it to other industry, actually there is no empty space there, because there will be someone covering it. For example, the group A of the clinician, they are doing the handover, and they are group B and also group C there, attending the patients. And most of this report, they show that the handover patterns depend on the patient attendance every day. For example, at the weekend, the handover pattern is very different, and also the manpowers are also very different. And there are also one very important things. At night, the manpower is much lower than in the daytime. So actually, the handover patterns will become something between 1 to 1, 1 to many, and many to 1, just because of this change. So within the day, actually, they have different kind of ED shift handover patterns. And in 6 research, they were initiated for improving their own practice in their hospital. But for the rest 91, they mentioned that they want to improve the ED work in general. And the research tools they use, 70 research use questionnaire or survey components, included the Delphi methods. 14 of them had a site observation components, 4 with a secondary data analysis, and the data came from the ED patient charts or hospital database. and 2 used the interviewing method. 22 of them reported their ethical approval status and their research duration in the ED from 1 to 7 months. And 5 research used pre and post intervention research method. And this is the most up-to-date findings. Actually, you can see the intervention too. Most of them are checklists and mnemonics. And for some, actually, this is only one research. They used the 3 components. First of all, they want to diverse the phone call outside the handover area. And they also use the overhead time to alert people that there is a handover currently in the hospital, in the department. They also use a lightweight movable pedestrian sign with a message, "Sign out around in progress. Please minimize the interruptions." So this is the path for me.